What if I told you that those randomized controlled trials you've been taught to trust as gospel aren't actually at the top of the evidence hierarchy? Heck, it's not even the systematic reviews or meta analyses that sit at the top. Today, we're joined by Dr. Eddy Lang, professor of emergency medicine at the Cummings School of Medicine in Calgary. From on site at FASTCAN 25 after his talk on evidence based medicine. Dr. Lang has worked with the World Health Organization and the International Liaison Committee on Resuscitation, developing the very guidelines that shape how we practice. He also helped develop the grading system that is now used by most major societies to make their recommendations. He's here to tell us why a positive randomized control trial doesn't automatically mean we change what we're doing in the back of the ambulance. If you've ever wondered whether you're following the evidence or just following the crowd, this episode is for you. Let's get loud and clear about what evidence based medicine really means. Eddy Lang, you just gave a talk here at FASTCAN on evidence based medicine. So, first and foremost, define for us what is evidence based medicine and what are maybe some common misconceptions?
Yeah, great question. So it's gone through some evolution. When it was first founded by Gordon Guide at McMaster University in the early '80s, it was really about making sure that the things we do are supported by studies. It's become a little bit more refined in the late in most recent iterations. It's about the judicious use of evidence combined with patient values and preferences to achieve the best possible outcomes. So, a little bit of a subtle distinction, but it points to the fact that the evidence is not always the star player and that there are sometimes other considerations that are coming into effect. So, I would say the common misconceptions are that it's all about whatever the study says. If the study says A is better than B, then that's gospel and you've got to follow it. That's really, it couldn't be further from the truth. Evidence-based medicine involves carefully understanding the limitations of studies, and it also means bringing a body of evidence together, ideally through a systematic review, to get a whole picture and not a biased picture that might come with just looking at a single study. So systematic reviews can be criticized as well. You used to hear them referred to as garbage in, garbage out, and two graders don't make a fourth grader. But I would challenge that. I think that if a systematic review is done well, it really speaks to what the current state of understanding on a particular topic is. So in Canada, you cannot get funding for a research project unless you've shown that a systematic review has been done, which demonstrates there's a gap that research knowledge needs to fill. And even the Institute of Medicine, when it came out with their statement on guidelines, they stated clearly that guidelines should be based on systematic reviews to really understand what works and what doesn't.
Yeah, and you in your talk talked about a hierarchy of evidence that we need to kind of understand as we're evaluating the literature. And what I loved about yours is actually a hierarchy that I hadn't necessarily seen before. Normally, we think about the systematic reviews and the meta analysis as at the top of that hierarchy, but you had something different up there.
Yeah, meta-analyses are systematic reviews, as I said, are essential core feature of evidence-based medicine, but they're not enough to decide an algorithm or make recommendations that are applied in practice. Because, for example, we know that industry will often fund trials that show marginal benefits at very high expense. So just because something is positive in an RCT doesn't mean we should adopt it. When you go to the level of the clinical practice guideline, you take all of these other aspects into consideration, especially if you're using the grade system. You're looking at feasibility, acceptability, equity, whether an intervention will actually make the healthcare system less fair or more fair, especially to vulnerable and marginalized populations. So in that schema, clinical practice guidelines are at the top because it's not only the systematic review, but it's taking the systematic review, putting it through a rigorous process and lens with all the key players at the table. And only at that point do you come out with recommendations that get followed, hopefully, within the paramedic world.
Yeah, it's applying that evidence to the real world because these studies are done in artificial. They try to make them as perfect as possible
Yeah.
to get to a specific answer, right? We're trying to get rid of all the confounders. But in the real world, the confounders exist, the challenges exist. And so, can we actually pull this off? Often becomes the question.
Exactly. That's the example I gave in the presentation. There's clear evidence that rectal diazepam is effective to stop pediatric seizures. But we felt when we discussed this with the paramedics who were part of our guideline that this should not be option one because of the way it might make paramedics feel uncomfortable. Parents might have concerns, and it should not be first line. So that's a good example of how that contextual element and the ethics and the societal standards, who knows, maybe in England it's not a big deal, or in France I understand they use suppositories for everything, so maybe it's fine there. But in the North American guideline it did not wash.
Yeah. What are the components that are needed to then change our practice?
First and foremost, you need a system that's nimble and can survey the literature for developments. I mean, it's becoming an increasingly fast and moving field. One idea that's come forth is the concept of living guidelines. So, one of the things about guidelines is they often take months to do. They're this huge document. They're often difficult to operationalize, and they become out of date once they're even published. So now we're seeing software and utilization of AI to make sure that as things change, we're on top of things. Also, I think integrating quality improvement into paramedic care and pre-hospital care is essential because it's one thing to, put forward an algorithm on sepsis or whatever it is, but if there's safety issues or competency issues, unless you know that, you're going to keep going ahead and blindly doing the same thing over and over again. So I think being able to follow changes in the literature, have a reliable mechanism to incorporate latest evidence, and a good comprehensive assessment of the existing evidence algorithms are the key features.
You mentioned AI. How is that going to start playing a role in our practice?
Well, we are seeing it already in our emergency departments through enhanced facilitated documentation. So our docs are walking into a cubicle with a program on their phone called AI Scribe, I think is the name of it. And they are basically having the note written by the phone listening in on the conversation and making sense of the interaction to write up the history and even to some extent the physical. So that's one straightforward example. But what I think is coming is more predictive elements. And, as I showed in that case of a alcohol withdrawal patient, paramedics should soon have access, if there's a consolidated electronic health record in their jurisdiction, to be able to see what a given patient has experienced in the past. That's probably the biggest predictor of what's going to occur in the future. So if person X responds best to this treatment for vomiting and nausea, or this treatment for pain, and we know the doses based on their previous dose response, then you could imagine that paramedics will have this fed at their fingertips and be able to perform what is essentially precision pre-hospital care. Some of the key decisions about, whether someone needs to be transferred to a tertiary care center, that decision making can be supported by point of care labs. It can help even do things like I used alcohol withdrawal as an example, but maybe the CWA scores can be calculated through AI in a very facilitated way. I know it's a very chaotic environment, the back of an ambulance, but if you can set up if you can determine that the CWA is X or Y, that might also help not only determine destination, but prioritize the patient's arrival and give the arriving team, the emergency team, a heads up as to what's needed and what should be done for that patient.
And offload some of those kind of cognitive tasks for the paramedic in the back of the ambulance as well.
Absolutely, absolutely, and get them back on the road
Yeah.
sooner, ideally. And AI, of course, will have a role in optimizing the flow of patients in the emergency department and determining which of those patients. You guys, when you guys come into our department, I'm sure you see these things that people are on stretchers, they're on monitors, and they're playing on their phones. Why is that happening while paramedics are ramping in the hallway and experiencing offload delay? Hopefully, AI will be able to identify way ahead of time which patients should be transferred off of monitor and stretcher quickly, which patients, even if they're waiting for a bed upstairs, can go to a low acuity area, And that will facilitate the movement of patients through the whole department and free up paramedics to be back on the road and do what they're meant to do.
Yeah. What about using AI to answer clinical questions or evaluate the kind of what evidence does exist out there?
Yeah, I didn't know how feasible this was until I heard about something I mentioned in the presentation called a service called Ask, ASK. It comes from a British group called Turning Research into Practice. They've been around for decades. They've been helping do searches and link databases. But this thing is almost magical. It's you just ask a question as you would ask it to a colleague or someone who you think is knowledgeable in the field, and this service, which provides 2 free answers before giving you a $50 a year subscription, and I have no interest in this, no financial involvement. So it will spit out after about 15 seconds of turning what would ordinarily take someone 3 to 4 hours to write up, including references and bottom line analysis and synthesis. So this service can actually read systematic reviews, read guidelines, put it all together, and spit it out in a very digestible format within a matter of 15 seconds, which is pretty remarkable.
Yeah, and I love the ability to get the source references too. So if you're interested and want to dive deeper, you can go to the actual source.
Exactly. And hopefully there will be systematic reviews informing the question or some landmark trials that help.
Yeah.
Now, I mean, for some questions, you're looking for different kinds of research. Sometimes if you're looking particularly for harms or side effects or diagnostic tests, you might be looking for a different kind of study. But in general, it's going to be randomized trials, systematic reviews, and meta-analyses that will, and clinical practice guidelines that hopefully will bubble to the top.
Great. The last thing that I think is really important for our listeners to understand is something that I think you had a play in developing, and that's this grade system. Can you explain that for us?
Yeah, so about 25. It was actually it's their 25th anniversary. Some folks interested in evidence-based medicine got together and said, you know what, the world of guidelines is a mess. There's over 100 different systems out there. Every medical society has kind of their home cooked version, and it's extremely difficult to compare apples and oranges. The other big problem with the guideline world before many years ago was that if you had a randomized trial, even if it was crappy and full of biases and problems, because it was a randomized controlled trial, it bubbled to the top, and people were able to say, "Oh, there's a randomized trial. We can make a level A or level 1 recommendation." And that is just so not the case. And grade helps you take a much more sensitive and critical eye to the evidence. It looks at the evidence across outcomes, not necessarily one study at a time. And that way, it can give you a much more sophisticated and nuanced analysis, both of what the evidence is saying and provides a very structured framework for how a guideline panel will review that systematic review and hopefully come out with sound recommendations. So currently, there are over 120 countries using the grade system. It's really become the common language in guideline presentations. And I showed how it works in the presentation. It's basically, you'll recognize it. This guideline panel, recommend. That's recommend is, and if they code that as a strong recommendation, that's an example of a grade-based recommendation.
Yeah, so there's essentially 4 approaches to that.
Yeah, so the recommendations come essentially in 4 flavors: strong in favor of one thing compared to another, conditionally in favor one thing over another, leaving a little bit of leeway for shared decision making and flexibility. And then the flip side is conditionally against and strong against. Now, there is technically a 5th category. If you really can't choose between A or B, you can sit on the fence. Grade discourages you from doing so, but you could say, look, we really just don't know. A could be better or B could be better. We just need more research and it would be too speculative for us to make a recommendation at this time.
Yeah, I love that. So essentially 2 recommendations, either for or against, where, hey, there's a lot of evidence. We feel very confident that A is better, the benefits outweigh the risks, or B is harmful, the risks outweigh the benefits. And then there's a middle section where, like, there's not perfect evidence, but we, after talking about all of the evidence, feel like conditionally we think this is better, but we're giving you some leeway to say maybe it's not.
Exactly. And we think that although there are only about 10% of all grade recommendations come in that strong flavor, those would suit themselves well to quality standards and to being really firmly embedded into EMS algorithms. The 95% that are conditional recommendations should be there as a more of a flexible option. It's probably going to be suitable for most people. But, if someone is really scared about hallucinations, then maybe that's not the person to give ketamine to for pre-hospital pain.
Yeah. Or sometimes you're going to have system factors, resources, barriers that just don't allow you to implement it.
Exactly.
Great. Thank you so much for educating our audience. Come on the Loud and Clear podcast and giving that phenomenal talk here at FASTCAN.
My pleasure. Thanks for the great questions.